April is one of our combined neuro-ophthalmology skull-base fellows for the couple of years, and probably about a minute into her talk, you will realize what a kind person she is just by her cadence and so forth. And that's a real boon to me because my cadence is a little bit different. I was born in Philadelphia. So April comes to us from New Orleans, where she did her ophthalmology residency, and as I said, is spending time with us on the skull base and neuro-ophthalmology service at Wills, and is just an absolutely wonderful, wonderful physician, extremely kind to patients. I have never, ever heard any patient say have a bad word about her at all. In fact, quite the opposite. She gets rave reviews. So April, with no further ado, here you go.
All right, thank you so much for having me. Let's go ahead and get started. So I will not be discussing any unapproved or experimental therapies or devices here. So here's our outline for today. We're first going to define dystonia and go through all the types of dystonia. Eyelid myokymia, blepharospasm, orofacial dystonia, hemifacial spasm, and kind of in their own separate categories, apraxia of eyelid opening, and aberrant regeneration of the facial nerve. So what is dystonia? Dystonia is involuntary muscle contractions. They can be sustained or intermittent, so-called tonic versus clonic, which then result in abnormal postures or repetitive movements. They can affect one muscle, groups of muscles, and muscles throughout the body as well. It's thought generally to be caused by damage or abnormalities to the basal ganglia, which is a motor control center in the brain. And it can be idiopathic, genetic, or acquired. Just briefly going over some facial muscle anatomy, focusing in on the eyelids, there are two major groups there, the protractors, which are involved in lid closure, and the retractor, which are involved in lid opening. The protractors are the corrugator, the procerus, shown here, that's kind of over by the brow and the forehead area, and then the orbicularis is that circular muscle going around the lids. The frontalis is the larger kind of forehead muscle here. The levator is not pictured here, it's deeper to the orbicularis. And then in the lower face of interest is the masseters and the platysma, which we'll kind of touch on later. These are all innervated by the facial nerve, also known as cranial nerve 7. It exits out by the ear and has 5 different branches that go to all of those muscles respectively. So now going into the separate types, eyelid myokymia, this is a fascicular contraction within the orbicularis muscle. So you'll see it as a twitching, flickering, rippling movement within the eyelids. It usually affects one side at a time and is associated with stress, fatigue, caffeine use, affectionately known as medical student's disease. I know I've suffered from this myself. It is usually not very bothersome to patients, so the treatment starts conservative first, avoid triggers, and will usually self-resolve. Very rarely, it can be the first manifestation of blepharospasm or hemifacial spasm. And here we have a sample video. And so you'll see here, kind of on the left lower lid, that's the area of focus here, that twitching, rippling, kind of low amplitude movement there. And then here's a close-up of it. So the next one, benign essential blepharospasm. This is an involuntary episodic closure of the eyelid. It's contractions of the eyelid protractors, the eyelid closers, which can be tonic, where it shows as the eye is closed for a long period of time, or clonic, where you get those multiple contractions. It can have a wide range of presentations from a mildly increased blink rate to forceful contractions resulting in functional blindness. This affects the eyelids only and affects both sides at the same time. It affects ages from 40 to 60 most commonly, females more so than males at about a 2 to 4 to 1 ratio, males versus females, and is about a prevalence of 1.6 to 30 people per 100,000 in the US, and about 2,000 cases are diagnosed annually here. It can be isolated, or it can be caused or associated with other conditions, which can be eye-related, like dry eye, blepharitis, intraocular inflammation, can be associated with medications for Parkinson's and other Parkinsonian type diseases like Huntington's, Wilson's, progressive supranuclear palsy. The cause is really not well understood. There's some thought that there is a defective mechanism in the circuitry. The normal blink response, the cornea will receive some kind of input. This is the so-called afferent limb, which is then carried back to the brain with the trigeminal nerve, cranial nerve 5, which then sends an input to the facial nerve, which is then seen as an output with the contractions of the orbicularis muscle. It is thought that either the trigeminal nerve is overly sensitized or the facial nerve is overactive or there's some kind of basal ganglia dysfunction in the deeper brain structures. And with this cycle, you can get into this kind of vicious cycle that feeds in on itself because once you get those spasms of the lids, that then can cause extra stress on the input branch that then just keeps feeding in on itself and you just get this really vicious cycle. Treatment can be conservative just with artificial tears, lid scrubs, tinted lenses like the FL41 lenses pictured here. Botox is one of the mainstays of treatment, targeting the orbicularis muscle to stop those contractions. And then you can also consider oral medications or excision of some of the orbicularis. A myectomy is what it's referred to as. This was just essentially showing blepharospasm, which was just these forceful contractions, both eyelids being affected at the same time with no lower face involvement here. Next, we'll talk about Meige Syndrome, which is sort of a blepharospasm plus, is how I like to think about it. You have the blepharospasms and you have the lower face involvement too. So you'll get like spasms of your tongue, the jaw, the pharynx, the face. And this is from those lower muscles that we mentioned earlier, the masseters and the platysma down in the neck. And with this, both sides of the face are affected at once. Similar age group is 30 to 70 years old. Mean age is about 55. Females, again, are more commonly affected than males, and a prevalence about 5 out of 100,000 people. It can actually start as blepharospasm and then spread to involve the lower face. Spread is more common in the first stages of the disease within the first 3 to 5 years. The thought is that it's caused by a dopaminergic and cholinergic hyperactivity, which leads to decreased functioning of the inhibitory neurons, abnormal sensory motor processing, and abnormal control of the cranial nerve nuclei and the brainstem by the basal ganglia. It can be a primary condition or a secondary condition, meaning caused or associated with something else. Some certain meds have been implicated, like antipsychotics, antidepressants, even antihistamines, head trauma, strokes, demyelinating disease, and other basal ganglia diseases like Parkinson's, Wilson's disease, Lewy body disease. Treatment, some people have usually figured out by the time they even come to see us that there are these sensory tricks they can use. It's basically just using these other stimuli to alleviate the spasm intensity. That's by like talking or singing or even like touching the brow and forehead to kind of reduce the spasms. And then the first line is actually a systemic medication for this for this condition. The anticholinergics and the dopamine blockers, basically blocking all those neurotransmitters that we just mentioned. You can consider Botox for this as well. but that's considered more if you're poorly responding to the medications first. And secondly, you usually reserve the Botox purely for around the eyelid involvement, as injecting around the lower face would cause even more trouble speaking or swallowing or chewing. And then for very refractory cases, some people have used deep brain stimulation too. And I have a representative video of one of my colleagues here showing us the bilateral, both sides being spasming here, both the upper and the lower face. And another thing I wanted to mention here is Brueghel syndrome. It's frequently mentioned alongside of Meige syndrome. It is a jaw opening dystonia, so you get this kind of in this picture here is what is the classic image of it. And then eyelid involvement, it depends on the source, whether they include it or specifically exclude it as part of the syndrome. Hemifacial spasm. This one is an involuntary upper and lower facial contraction as well, except this time it's only on one side of the face. Population affects like 50 to 60 years old women, again, more commonly affected than men, and a prevalence about 8 to 15 per 100,000 in the US. The cause of hemifacial spasm, it is a compression of the facial nerve anywhere along its path. Which starts off in the nucleus and then exits at the junction of the pons and cerebellum here. And then you're kind of coming more superficially onto the face. You can also run into the parotid gland here, which can also compress. But the most common cause of hemifacial spasm is an abnormal artery compressing at the point it exits the brainstem, right in this area here. Can also be idiopathic too, or basically an unknown cause. So really any tumor anywhere along that path, or even a demyelination or stroke along that path can cause hemifacial spasm. And here we have a really great example of an actual MRI showing that an abnormal artery compressing on the facial nerve, right in this area here. So treatment is Botox injections over the kind of the eyelid area as well. And then if there is an abnormal vessel, another consideration would be neurovascular decompression surgery. So you're essentially putting a sponge in between that vessel and the nerve to relieve some of that compression. So this video will show a pre and post-op actually. Here you can see both the lids twitching and the lower face twitching just on one side. And then this is post-op. He underwent that neurovascular decompression surgery, and you can see his spasms have completely resolved. He has a little bit of residual facial weakness, which we'll see when he does his contractions of the lids, and they'll show us a smile too a little bit later on. But still really good function there. Really great result there. So this is just kind of a visual representation of all three that we've talked about so far. Blepharospasm, just the eyelids, both sides, the orofacial spasm, upper and lower, both sides of the face, and hemifacial spasm, upper and lower, but just one side of the face at a time. And then in its own category is apraxia of eyelid opening. This is an inability to open the eyes voluntarily after closing the eyelids in the absence of squeezing. Both eyes are affected here. It is commonly associated with blepharospasm as well as other conditions like we've listed similarly, Parkinsonian types, progressive supranuclear palsy, and other cranial nerve CNS lesions. Um, but it can also be isolated too. It's a very poorly understood disease process and very challenging to treat. It's sort of in that same like basal ganglia area that they're thinking is the area of pathology, leading to like an inhibition of the levator, which is one of those protractors that we mentioned that opens the lids. Very, very challenging to treat. Most people will start off by giving Botox, targeting the pretersal area. The orbicularis basically right over the top of the lid. But they can be refractory. There have even been some cases that have required up to 120 units of Botox and still had no response. So these may be actually more of a surgical treatment with the myectomy, ptosis surgery, frontalis sling, or eyelid crutches. There is about a 7% prevalence in like just a general population of blepharospasm patients. They found a 7% prevalence of the apraxia component. And in another study where they were specifically looking at cases that were non-responsive to Botox, they found an even higher prevalence of about 25%. And here we have a video here. He'll close his eyes here voluntarily, and then he's unable to open the eyes, and you can see that he's not squeezing or contracting. It's just an inability to open the eyes. And then this is very common with this condition too, the manual lifting of the lid to get it started. And then once it's open, he's able to keep the eyes open. And then lastly, I wanted to talk about aberrant regeneration of the facial nerve. This is also in its own separate category as it is an involuntary movement, but it's accompanying a voluntary movement. The cause is nerve regeneration after a facial nerve palsy, resulting in abnormal connections between the peripheral branches of the facial nerve. So these branches out here on the face will form abnormal connections between them. There are different types, ocular, oral, synchesis, that will lead to either when you're voluntarily blinking, you'll get involuntary mouth movements, or if you're moving, and then vice versa as well, whether you move your mouth voluntarily and you'll get involuntary eye movements. And then crocodile tears is another form where you tear when you chew, and a hypertonicity type where you just kind of contracting at rest. And we have a great example here from Dr. Gold. So her right side is the affected side here. So here she's doing voluntary eye movements, and then you'll see like occasional kind of mouth contractions down here that these are involuntary. And then now when she's doing voluntary mouth movements, you'll see that this eye is closing involuntarily. And then this voluntary, involuntary. And then down here, voluntary, involuntary closure. Okay, and then this is just a summary table of everything we've talked about today. Just the laterality wise, remember that blepharospasm and apraxia of eyelid opening are just affecting the lids, whereas the orofacial spasm and hemifacial spasm will affect upper and lower. Laterality-wise, hemifacial spasm will affect one side, whereas the rest will affect both. The cause is largely unknown or poorly understood for these conditions, except for hemifacial spasm, which is usually compression of the seventh nerve. Botox is a mainstay of treatment for all of these. Except for orofacial spasm, you'll want to consider systemic medications. And hemifacial spasm, if you have that vessel compression, you can consider that decompression surgery. And then apraxia in a category all on its own. Many options there that may need a combination of all of those to best manage it, as it's a very challenging component here. And here are my references. Thank you all so much for having me.